Hepatocellular cancer survival. What factors are important? If you or someone you love has been diagnosed with hepatocellular carcinoma, you likely have one question at the forefront of your mind. What determines survival? This video will walk you through the key prognostic factors that shape outcomes, survival rates across different treatments, and why expert multidisciplinary care matters by way of evidence-based content professionally sourced by Saboor, consultant surgeon. Hepatocellular carcinoma is a primary liver cancer that typically develops in the setting of chronic liver disease. It is an aggressive tumor where survival depends on a complex interplay between the cancer itself and the health of the underlying liver. The median survival following diagnosis ranges from approximately 6 to 20 months, but this number masks tremendous variability. Some carefully selected patients achieve 5-year survival rates exceeding 70%, while others have far more limited time. Before we dive deeper, let us establish what we are dealing with. Understanding what affects your prognosis is not about creating fear. It is about empowering you to have informed conversations with your healthcare team and understand why certain treatment recommendations are made. Tumor size, number of tumors, and particularly vascular invasion, meaning whether cancer cells have invaded blood vessels, are critical determinants of survival. Gross or microscopic invasion of the portal or hepatic veins significantly reduces survival prospects. In one study, there were no 3-year survivors among patients with vascular invasion, compared with a 32% 5-year survival rate in those without it. For carefully selected patients with solitary lesions under 5 centimeters without vascular invasion and no invasion of blood vessel branches, 5-year survival rates can reach as high as 78% following surgical resection. Tumor size matters because both spread within the liver and spread beyond it are more common with tumors larger than 5 centimeters, particularly when associated with venous invasion. However, here is something that might surprise you. Large solitary tumors without vascular invasion can have the same prognosis as small solitary tumors without vascular invasion. It is the vessel involvement, not just size, that matters most. This is absolutely critical to understand. As a general rule, the degree of liver dysfunction, measured by systems like the Child-Pugh classification as A, B, or worse, C, and the MELD score, the pressure in main liver vein called portal vein rises due to the scraying, which too is a poor sign. Often the deteriorating liver function limits long-term survival in patients with cirrhosis, which is severe scarring of the liver, rather than cancer itself. The presence of cirrhosis creates what physicians call a competing risk. You face not only the cancer, but also the risk of liver failure and the development of second primary cancers. One multi-institutional study of 591 patients who underwent resection of hepatocellular carcinoma found that while tumor features predicted 5-year survival, they had no bearing on survival beyond 5 years. In non-cirrhotic patients, 4-year survival was more than twofold higher compared with cirrhotic patients, 81 versus 35%. For patients with compensated cirrhosis, meaning the liver still functions adequately, median survival following resection of tumors less than 5 centimeters can be comparable to non-cirrhotic patients, but outcomes are less favorable in those with underlying active hepatitis, indicated by elevated liver enzyme levels. Alpha-Fetoprotein, abbreviated AFP, is a protein produced by some liver cancers that can be measured in your blood. While less than 20% of hepatocellular carcinomas produce very high levels, when levels exceed 400 nanograms per milliliter, they are nearly diagnostic with specificity greater than 95%. More importantly for prognosis, AFP level at diagnosis correlates with outcomes. In one study, 5-year survival for patients with serum AFP greater than 10,000 nanograms per milliliter at diagnosis was significantly shorter compared with those with levels under 200, only 7.6% versus 33.9%. High AFP levels are associated with poorly differentiated tumors, meaning more aggressive cancers. The preoperative AFP level, presence of multiple tumors, and microscopic vascular invasion were important predictors of 5-year survival in surgical patients. The best long-term survival is observed after surgical therapies, but most patients are not eligible because of tumor extent or underlying liver dysfunction. In Western countries where hepatocellular carcinoma is less frequently associated with chronic hepatitis B infection, 5-year survival rates following resection range from 27 to 49%. This is better than in locations where hepatitis B is endemic, and incidence rates of hepatocellular carcinoma are high, where 5-year survival is 11% or less. For liver transplantation in carefully selected patients, 3-year and 5-year survivals can reach 72 and 68%, compared with 64 and 44% for resection, 54 and 36% for percutaneous ethanol injection, and 32 and 22% for transarterial chemoembolization, a procedure where chemotherapy is delivered directly to the tumor through its blood supply. Overall, the prognosis of patients with this tumor remains poor, with an overall 5-year survival rate of 18% across all stages, reflecting that many patients are diagnosed late with advanced disease. Hepatocellular carcinoma is frequently diagnosed late in its course for 2 reasons. the absence of symptoms in patients with early disease, and the reluctance of some clinicians to provide surveillance for high-risk patients. The goal of surveillance is to detect tumors when they are 2 centimeters or smaller in size, so that the entire range of treatment options are available. The 5-year survival rate for patients whose tumors are detected at an early stage and who receive treatment exceeds 70%. By contrast, untreated patients from the time of diagnosis have a median survival ranging from less than 1 to 3 months in high-incidence areas to between 2 and 4 months in relatively low-incidence Western countries. This stark difference underscores why surveillance and early detection matter so profoundly. But here's where it gets interesting. Even with poor prognostic factors, carefully selected patients can undergo aggressive treatment with excellent outcomes. Some patients with major vascular invasion benefit from hepatic resection, and long-term survival can be achieved following resection of multinodular hepatocellular carcinoma. Algorithms that exclude patients from aggressive treatment based solely on the presence of poor prognostic factors should not supersede careful multidisciplinary evaluation of each patient before treatment plans are devised. Request copies of all your imaging reports and blood work, particularly your AFP level, liver function tests including Child-Pugh classification, and tumor staging according to the TNM system, tumor, node, metastasis. Understand whether you have cirrhosis, and if so, what grade. Know the exact size, number, and location of your tumors, and whether vascular invasion has been identified on imaging. This information will be essential for every conversation you have with specialists moving forward. Based on my tumor characteristics and liver function, what is my realistic prognosis? Am I a candidate for potentially curative therapies like resection or transplantation? If I have cirrhosis, how does that affect my treatment options and long-term survival? What is my AFP level, and what does that tell us about my cancer's behavior? Should I be evaluated by a multidisciplinary team at a specialized center? These are not confrontational questions, they demonstrate you are an informed, engaged participant in your care. Contact your healthcare team immediately if you develop new or worsening abdominal pain, yellowing of your skin or eyes called jaundice, confusion or altered mental status, vomiting blood or passing black tarry stools, significant abdominal swelling, or high fever. These may indicate complications of liver disease or tumor progression requiring urgent attention. We strongly urge that patients with hepatocellular carcinoma, especially liver-localized disease, be referred to specialized centers of excellence with multidisciplinary expertise. The wide variety of treatments are offered by different specialties: surgery, transplant hepatology, interventional radiology, radiation oncology, and medical oncology. Multidisciplinary teams provide more thoroughly vetted recommendations and are less likely to recommend suboptimal therapies driven by individual provider expertise rather than your individual needs. Studies confirm that establishment of multidisciplinary hepatocellular carcinoma clinics is associated with improved clinical outcomes and survival. Hepatocellular carcinoma prognosis depends on tumor stage, vascular invasion, liver function measured by Child-Pugh class and portal hypertension, and AFP level. Early-stage detection dramatically improves 5-year survival from under 20% overall to over 70%. Treatment modality matters profoundly, with surgical options offering the best outcomes when feasible. Multidisciplinary evaluation at specialized centers provides access to the full range of options. This information is for education. Always discuss your individual situation with your healthcare provider. For comprehensive, evidence-based information, the American Association for the Study of Liver Diseases provides clinical practice guidelines on hepatocellular carcinoma prevention, diagnosis, and treatment at aasld.org. The European Association for the Study of the Liver offers management guidelines. Thank you for watching this video.